Lee Brunswick is a 63-year-old male with past medical history of hypertension, type 2 diabetes, hyperlipidemia, and chronic kidney disease, stage 3, who presents to the emergency department with a chief complaint of short of breath when walking for the past 10 days. He states that it is better with rest and it's worse when walking a short distance or climbing stairs. He wasn't doing anything when it first started that he can remember, and he says that he has experienced this in the past, but it's never been this persistent, and it's slowly been worsening since its onset. It's constant throughout the day. He describes the quality as he can't catch his breath, and it states it is severe. He couldn't leave the house for the past 2 days. For pertinent positives, he has a weight gain of 5 to 7 pounds in the last 2 weeks, swelling of bilateral lower legs, and orthopnea. He denies fever, chills, sweats, chest pain, palpitations, cough, sputum production, or lightheadedness and dizziness. His surgical history: he had an appendectomy in childhood, hospitals unknown. His father is deceased at age 70 due to a myocardial infarction. Mother's also deceased at age 74 due to stroke, and brother is alive at 65. He also has a history of type 2 diabetes. Social history was not obtained. He's allergic to penicillin and he has a rash. For medications, he's taking lisinopril 20 milligrams by mouth daily, metoprolol succinate 50 milligrams PO daily, atorvastatin 40 milligrams by mouth daily, metformin 1,000 milligrams by mouth twice daily, and aspirin 81 milligrams daily. His vitals: his blood pressure was high at 148/88, heart rate of 102, and respiratory rate of 22 breaths per minute, and his oxygen was low at 91%. He is alert, oriented, sitting comfortably. He's in no acute respiratory distress, but he does appear mildly tachypnic. His head was normocephalic. He had no jugular venous distension at 30 degrees, but at 45 degrees there was mild neck distension noted. Cardiovascular: he was tachycardic, regular rhythm, S1 and S2 were noted, no murmurs, rubs, or gallops. Respiratory: he was mildly tachypnic. He did have bibasilar crackles on auscultation, but no wheezing or rhonchi. No significant findings in the abdomen. Extremities did have 3+ pitting edema of the bilateral lower legs and mid-calf, no erythema or warmth palpation. And neurological had no significant findings. His BNP was significantly elevated at 780. His glucose, BUN, and creatinine were also elevated. Serum sodium was decreased. Troponins were normal. EKG showed sinus tachycardia, and the chest X-ray showed cardiomegaly with congestion and interstitial edema. The assessment is that this is congestive heart failure, so we are going to admit him inpatient. Follow-up per the cardiologist's recommendations. For further workup, we'll do an echocardiogram, repeat BNP and BNP, and a repeat EKG. Like I said, refer and consult cardiology. Treatment we're going to do for pharm: 20 milligrams of furosemide IV, bolus. Non-pharm: monitor electrolytes and fluid restriction and supplemental oxygen. And for patient education, we're going to look at their dietary habits and make sure they're on a low sodium diet and assess if they smoke or drink, and educate them to start exercising more frequently.